non-arthroplasty options for avascular necrosis. And we need to know this because a large percentage of the patients diagnosed with osteonecrosis of the femoral head are younger than 65 years old and may need a re-revision in their lifetime. The patient selection is important because of the radiographic or pre-collapse or post-collapse, size of the necrotic segment, amount of the femoral head depression, and acetable involvement with signs of osteoarthritis. Patient's age, of course, in the younger people who want to go for a joint preserving operation, activity level, general health and comorbidities. If this is bad enough, then you go for a one-shot or more surer shot of hip replacement, and the duration of symptoms, because that has a duration to play, especially in core decompression. The better results when a mean duration of symptoms was 6 months as contrasted to 11 months. The accuracy of the staging is extremely important by plain radiographs, MRI, CT scan, arthroscopy, as you just heard, and also the operative findings, because if you find something which was not detectable before, you may have to change into a total hip replacement occasionally. And this, in the arthroscopy finding, there's a loose infarct over there, which is no way you can keep it and go away. The non-arthroplasty options, therefore, if you look at the logarithm, are non-operative. And of these, the restricted physical activities, pharmacological and biophysical agents. And if you look at the operative options, they're basically core decompression, osteotomies, bone grafting, non-vascularized and vascularized, stem cell therapy, and cementation. The restricted physical activities have been shown that greater than 80% went on to a total hip replacement in 3 years. But there are incidences of spontaneous healing, and so early asymptomatic small lesions are the regions where 15 to 24 hips improved in these cases, but remembering that their 25% showed a time-dependent decrease in the size of the lesion. But the necrotic area has to be small. And this is a picture, normal hip, developing AVN, spontaneous healing in 2 years. Pharmacological agents, and the new interest has been on alendronate, where Sanjay Agarwala had a paper on this, published in a little while back in 2005, and he's followed it up later, which I'll come to later, in which there was disability reduction and only 6 required surgery out of the 60 patients, 100 hips that he followed. The 40 patients with Steinberg stage 2 or stage 3 osteonecrosis femoral head treated with alendronate in the control group or assigned in the alendronate group, and there was another control group. And in a minimum of 24 months, only 2 out of 29 in the alendronate group had loss of femoral head integrity, compared with 19 of 25 hips in the control group. Alendronate and Sanjay Agarwala followed this up recently with 395 hips with AVN. We were treated with oral alendronate for 3 years, with a mean follow-up of 4 years. And there was improvement in the clinical function, a reduction in the rate of collapse, and a decrease in the requirements of THR compared with the findings of other studies in which no treatment was given. And some benefits was noted even in Ficca-Dalit stage 3. Statins have been shown, especially in steroid-induced osteonecrosis, in which persons taking statins along with the steroids had much less incidence, only 1% of 284 patients, as those who were not taking statins, 3 to 20%. Pharmacological agents like stanozolol and enoxaparin has been in the case of fibrinolytic disorders, where the early stages of osteonecrosis in the femoral head at 2 years, 31 or 89% of the 35 hips had not required surgery and still had Ficca-Dalit stage 1 or stage 2 disease. And stanozolol used in a case of only 4 cases. Biophysical agents like electromagnetic stimulation, extracorporeal shock wave therapy, and hyperbaric oxygen has been tried, not been approved, and has not really stood the test of time as yet. Core decompression, in a meta-analysis of the outcomes of core decompression in 1,206 hips treated in 24 studies up to 1995. The best results were observed naturally following the treatment of early stage lesions, and 84% of patients with stage 1 and 65% of patients with stage 2 had a successful result. But here they used multiple small better results. If you look at osteotomies, it moves the segment of the necrotic bone away from the weight-bearing region. So there are 2 types of osteotomies, really: rotational transtrochanteric and angular or intertrochanteric, varus or valgus. Rotational transtrochanteric is the basic work of Sugioka, bone flap based on medial circumflex femoral artery. A large translation is possible, as a very difficult operation, prone to non-union, and most importantly, total hip replacement difficult and more prone to infection, and has given varying results in different hands, so it has not gained popularity. This was a case of an 18-year-old with this, treated, going to AVN, treated with this, the Sugioka operation of the rotational osteotomy, and later on At 3 years, good revascularization in this region. Angular osteotomy works well in young with good ROM and small lesions, varus of valgus stains, and fixation done 2 months, 11 years. Non-vascularized bone grafting treatment of pre-collapse and early post-collapse lesions when the articular cartilage is relatively undamaged. The avenues through which is a cortical graft through a core tract made in the femoral neck, trapdoor made to the articular cartilage of the femoral head, and window made in the femoral neck at the base of the head. And try any of those, but these were the findings. 15 hips, 12 years, 87% good results, 18 to 20% MFU clinically improved, and this one, 8 of them went on to THS, but 18 were clinically improved and 70% had no progression. Non-vascularized bone grafting, coring, BMP with prepared bone graft, 17 hips, no conversions, 14 had Harris scores greater than 80. But the problem remains they're not predictable. Vascularized bone grafting, so this allows decompression, structural support, and restores the vascular supply, fibula iliac crest mainly. Arbiniak, this is one of the many papers that were there, of 103 osteonecrotic hips. 2 out of 19, the pre-collapse state, went on to THR, 5 of 22 in post-collapse early stage, and 24 of 62 in advanced stage went on to THR. Multipotent stem cells have been used, 189 hips in 116 patients, and success, no THR in 136 out of 145 hips in pre-collapse, 19 of 44 in the post-collapse group. Cementation has been tried, 5 years, 14 hips had minimal pain out of 16 in sickle cell anemia disease. And the immediate weight bearing could be done, no result on the long term. Combined operation, what Professor Bakshi practiced and did here, curettage, multiple drilling with small drill holes, cancellous bone graft, muscle pedicle bone graft, quadratus earlier and for posterior lesions, TFL base down and more anterior lesions, chelectomy in advanced cases and adductor tenotomy in some. And this was an operation we had great experience on. And these were his results in the stage of success, excellent and good results going on to stage 4. But this was the staging of Marcus. And this is one of his cases of steroid-induced avascular necrosis with a hip score of 14 and a 35-year-old patient. This is a CT scan showing that. And results at 8 years after bilateral quadratus femoris grafting from the posterior approach. So conclusion, diagnose early, treat early, preferably one that does not create difficulty for subsequent THR. Radiology may not match symptoms, and that is important because people may go on like that even with a radiologically compromised hip, but with near bearings and implants, age for arthroplasty is dropping. Thank you.